by injecting filler, by advancing the mandible, you get rid of the hypercontraction. Now, on the other hand, what you said, with the aging process, etc., the hyperactivity. So I believe both points of view are valid.
I think very interesting this point about combinational treatment and what causes what. Certainly, we don't have a lot of conclusive insights about that, but I think we should always think of ways to combine the two treatments for the better outcome. Although now there's more insights coming from combination treatment. Mr. O'Connor, you had a question.
Can I ask the panel, do they all use local anaesthetic before fillers, and is that a choice over the patients prefer it?
Yeah, you can go around.
I think Ali is the one who converted me when I saw him injecting, was it 3 years ago at Whitmore? So yes. Local anesthetic.
In this case, let me qualify. Yes. So you inject now all patients in mid-phase. Let's specifically talk about the mid-phase. Do you inject all patients in the mid-phase with local anesthetic before? With adrenaline? I'm very proud of you. Well, in a way, I actually don't do that consistently, and two factors which make me personally use that. The first one, the patient's pain threshold. So if I know the patient, if I have treated them before, and if I am going to be supra-periosteal or away from any danger zone that I consider to me danger zone, I would be injecting them without local anesthesia. But if I don't know the patient, if the patient has not had a lot of treatment before, or I'm going to be close to my own comfort zone, like not in my own comfort zone, then I prefer for them to be anesthetized, and also I would like to be sure that I have silenced their arteries in that area.
Similar to you, I don't always, but yes, in some situations I do.
Most of the time actually. So, and I do a lot of intraoral. So, whereas Fahad will go around the piriform fossa extraoral, I'll go intraoral, and just a variation because it's easy for me because I've got all the stuff there. Being a dentist, so it's just easy. Lidocaines everywhere.
I believe it comes from the fact when you are a plastic surgeon, you know what is the difference? I already said that between a plastic surgeon and God.
And the gun.
And God.
And God. God.
God doesn't think that he's a plastic surgeon. That's different. But anyway, surgeons, we work in complete silence. The patient is, asleep, or even if, let's say, 90% of my surgery is under local anesthesia, and it can take 5-6 hours, facelifts, etc. There is an anesthesiologist, doctor, and the patient is sedated. So I need to work in peace. That's very important for me. So probably it doesn't mean that what works for me would work for everybody. But when I started, as I said, until 2009, and I started my clinic, I have a small hospital in Casablanca, I started in 94. From 94 to 2009, I had barely injected 8 syringes. So I had zero experience. Why? Because I couldn't stand being in a room with the patient saying, do this, don't do that, etc., etc. But then these products came out, these strong hyaluronic acids, and mostly hyaluronic acid that can stay over 2-3 years. I decided to go for it, and in order to quiet the patient, And in order to move as I want without her reacting, I prefer to put local anesthetic on top of the fact that obviously it closes all the arteries. That's for me fundamental.
Dr. Ejakimi?
I think some people here are plastic surgeons or surgeons, but for me, I come from, although I've done surgery in the past, my practice until a few weeks ago was in a more commercial setting. And I think that's where a lot of the students and a lot of people start injecting start. And I think in order for us to be able to inject patients, having 16 minutes to pre-treat them with adrenaline and then have the time to keep them in the office setting for 2 hours after would require a huge shift.
Yeah, but that's not for everybody.
Yes, a huge shift in practice for our competitors and just in the industry in general. It's challenging to do that. Today I think I'm going to look at my practice as well, because if I don't often use adrenaline. I treat thousands of people, but I almost never. And I think if we decide to do this, it has to be a shift in the way everybody's doing it. Because if you're injecting your patient with adrenaline, they leave the office with lip asymmetry, they're unhappy, they want to come in, have the procedure and go home like nothing happened. So I think we have to think about that.
Yes, I really think that's a very insightful point, because the difference in population, the difference of who you are, I think in a way, if you are working for somebody who's taking the liability versus you are working in your own clinic, I think that there are lots of factors working there. And maybe I encourage all my colleagues at Queen Mary University, for the students who have not yet decided on their dissertations, or those who are in year one, most of you here in year one, I really hope that one of you will be inspired and maybe do their dissertation in a kind of a systematic way to look at this question. Because we really need an evidence here, and if we don't have an evidence, maybe we have to create it. Maybe we have to work together and see comparatively if there is cost effectiveness issues, if there is risk association, patients' comfort. What's the patients want? Do they want to go and not be able to raise their eyebrow because they had adrenaline there, or they want this lunchtime? And whether we should actually or not resist the desire for a third party or a clinic to say, come on, chop, 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 you have to treat patients very quickly, and introduce standards that will have the patient's interest at heart rather than any other factors. I think this is very important. We can go on and on, but maybe I will ask for one more question if somebody have different to this. Yes, Donna?
Thank you. I have a question about the study on the nasolabial folds versus the malar fat pad treatment. A comment as well as a question. The question is, what was the volume difference for the malar fat pad and the nasolabial fold? And the comment is, just to echo what's been said, it's about patient affordability. That if you're using 3 times as much or twice as much in the fat pad area, the patient is going to find it's not affordable for them potentially.
This is the live one where they injected before. The injectors were not given a specific quantity. They were told to inject as much as they felt needed to improve the WRS scale by 1. So the amount was variable.
It would then be very interesting if somebody was doing a dissertation to actually look at that and measure it, because I think that could be a very important addition.
Another topic. So let's go forward with the program. We have now a hands-on activity 2. So there is no